in emergency room, hyponatremia in emergency room. So whenever the sodium levels in our body is below the normal range, that is 135 to 145, we can call it as hyponatremia. That doesn't mean that whenever the sodium level is less than 135, they can have symptoms. They may not have symptoms. Most of the patients who come with hyponatremia have absolutely no symptoms. They may have mild weakness. Whatever it is, when the sodium levels are less than 135 milliequivalents per liter, we call it as hyponatremia. And in a true hyponatremia, the level will be, the osmolality level will be less than 275. Okay. So when the sodium levels are low, you know that the osmolality of blood will be low. That means the osmolality of blood will be less than 275. Pseudo hyponatremia is one condition. It is not very common, but there are conditions where you can get pseudo hyponatremia that you should remember. One is very high cholesterol level, very high proteinemia, like multiple myeloma. And there are some common conditions. There also you can get pseudo hyponatremia. One is hyperglycemia, like diabetic ketoacidosis. When you see the patient's sodium levels, it will be falsely low. You can correct the sodium concentration by adding 1.4 millimole per liter for every extra 100 milligram deciliter in blood glucose. You can calculate and correct it. We have three important types of hyponatremia. This is normal water, normal sodium. Hyponatremia with normal ECF. Here the water levels are normal, but sodium levels are less. Okay. That is either because of the sodium loss through kidney or patient is not taking adequate sodium. So both can produce normal water with low sodium. There is a condition called as SIADH that also come here. Clinically, patient will not have excess water or low water. Normal water is there clinically, and sodium levels will be low. Urine sodium loss can be there. So SIADH comes under this category. Whereas hypervolemia with hyponatremia, sodium levels are actually normal. Volume is excess. You see the volume from here. This one volume is excess. So increased amount of volume that occurs in volume, increased conditions like cardiac failure, kidney failure with hypoproteinemia, other reasons for hypoproteinemia, hypoalbuminemia, anemia, liver failure, where all patient can have excess water with normal sodium. Here patient can have a relative hyponatremia. Water excess is there, that's why you get hyponatremia. There is a condition called as hypovolemic hyponatremia. The volume is low here, sodium also low. Okay, like patient is having severe vomiting, diarrhea, all these things you can get hypovolemic hyponatremia. So this one we have discussed three important types depending on the volume: normal ECF volume, increased ECF volume, low ECF volume. One important condition you should remember here is SIADH. We will discuss about SIADH in detail afterwards. Now what is SIADH? Syndrome of inappropriate ADH secretion. And persistent and excessive release of ADH can produce water retention. Remember, water retention is a feature of SIADH, but clinically you don't see edema. That is the difference between hypervolemic hyponatremia and normovolemic hyponatremia due to SIADH. SIADH actual water retention is there, but the volume excess is removed. Excess volume is removed by volume sensitive natriuretic mechanism. I am not going to the details of that, but the excess volume which will be removed by the natriuretic peptide mechanism, so that you don't see clinical increase of water, you don't see edema in these patients, but actually there is increase in water in the body. That's why patient is having hyponatremia, along with this excess water, patient loses large amount of sodium through kidneys. So this one occurs mainly due to some CNS infections, lung malignancy, some drugs and post-surgical events like that. So what are the clinical features of sodium? Sodium mainly affects our brain and neurological tissue. Brain cells are there. When the sodium levels are normal, there is no problem to the brain. If the sodium increases, what will happen? Water will come out from the brain cell. When the sodium is low, water will go inside the brain cells. So brain is the main organ which is affected in hyponatremia. So depending on the level of hyponatremia, you can have anorexia, headache, nausea, vomiting, lethargy. Moderate hyponatremia, you can have personality change, muscle cramps, muscle weakness, confusion, ataxia. Severe hyponatremia will produce drowsiness, diminished reflexes, convulsion, coma, death. So remember, weakness, neurological weakness, not specific neurological weakness. Weakness is the main problem in the hyponatremia, and low GCS and convulsions. So three things you should remember. So lethargy or weakness is the main feature, then low GCS and convulsions. Now when you have a hyponatremia case, don't think too much. You have to check the serum osmolality. If the osmolality is less than 250, 270, that is an actual hyponatremia. If it is more than 270, you have to think about hyperglycemia or mannitol, something like that. So pseudo hyponatremia come into picture. So hyponatremia with low serum osmolality only we are going to check. Some books might have given the level less than 280, some books might have given the level 270. That doesn't matter. If the serum osmolality is towards the lower side itself, you should understand this patient is going for a hypoosmolar hyponatremia. So that is a true hyponatremia. We are only going to discuss this type of hyponatremia because clinical features will be, because of hyponatremia, clinical features will be produced only in this type of hyponatremia. Here there is no clinical feature, here also there is no clinical feature because of hyponatremia. So that is very important. Now the first investigation will be after getting low sodium, you will check the osmolality. If osmolality is low, you should understand that it is a true hyponatremia. So the next set of investigation will be urine sodium and urine osmolality. You should remember that the serum sodium level are maintained by one, you are taking salt. Every day we are taking salt. Other one, kidneys are losing salt. Okay. So what are the reasons for depleted sodium levels in the blood? Either the patient is not taking or not getting the sodium, or patient is losing sodium, especially through kidneys or through stools, vomitus, all these things. So diarrhea, vomiting through kidney or not taking. These are the reasons for hyponatremia. Or like SIADH, there is an excess water with sodium loss. So when you have a patient with hyponatremia, primarily you have to see whether the patient is losing sodium through kidney or not. So you ask for a urine sodium. When you have a hyponatremia, normally body's response is to try to maintain the equilibrium. Body will try to prevent loss of sodium. If the patient is having hyponatremia, if kidneys are normal, urine sodium level will be less than 20. If the urine sodium level is more than 20, then the reason is kidney. The salt is lost through kidneys. Here you can have SIADH, salt wasting nephropathy, diuretic therapy, hypoaldosteronism, cerebral salt wasting. All these conditions come here if the sodium levels are more than 20 milliequivalents per liter when the patient is having a hyponatremic state. Then you should remember that if the urine sodium is high, normally you get a high osmolality. So if the urine sodium is excess more than 20, you get a high urine osmolality. So that is a classical feature of SIADH. So low sodium, low osmolarity, increased urinary loss, increased urine osmolarity. That is typical feature of SAADH. Now, hypotonic hyponatremia, that is not actual hypovolemic hyponatremia can be caused by GI losses. Okay, so hypotonic hyponatremia, if the serum osmolarity less than 280, there is a true hyponatremia. There are reasons for that we have discussed. I am not going to the slide again and again. Now, other hyponatremias also we have discussed, isotonic and hypertonic. Hypertonic is a very common clinical problem, especially in hyperglycemia. So, when the sugars are 700 or 800, okay, 700 or 800 like this, you can see the sodium levels will be low. Okay, but if you calculate the corrected sodium, it can either be normal or near normal. Okay. Now, how to investigate? That is very important. If the plasma osmolality is low, you should diagnose it as a true hyponatremia. Then look at the patient, whether the patient is having excess volume, edema is there, or dehydrated, or normal volume. Okay. Clinically, it is normal. Sometimes patient can have fluid excess inside the body, but we are not seeing it. That's all. Okay. If the excess volume is there, cardiac failure, liver failure, nephrotic syndrome, kidney failure, all these things. If it is normal, you should suspect SAADH, and you have to rule out hypothyroidism and adrenal failure before diagnosing SAADH. One of the condition comes here exactly like this is urinary tract infection. So, urinary tract infection, due to the injury of the tubules, you can lose large amount of sodium through the kidneys. So, when there is an infection, patient can lose large amount of sodium through kidneys. So, serum sodium will be low, serum osmolality will be low, urine sodium will be high, urine osmolality will be high. That exactly mimics SAADH, but since there is an infection, SAADH is ruled out. You are supposed to treat only infection, UTI. And the other condition is if ECF is decreased, you should see whether the patient is losing both through kidney or extra renal causes. If it is through kidney, the renal sodium levels will be high. If it is through some other route, urine sodium will be low. So that is evaluation part. Management also follows according to this chart. So if the patient is having hypovolemia, dehydration, give water with salt, that is you can give NS or NS with salt. That is a treatment, oral salt. Okay, that is a treatment. If the patient is having hypervolemia or edema with hyponatremia, your main aim should be fluid restriction and fluid removal and salt restriction. These are the three strategies in hyponatremia in a case with cardiac failure, liver failure, kidney failure, nephrotic syndrome, all these conditions. Normovolemia with hyponatremia, I have told SAADH one important cause, then UTI is another cause. SAADH treatment is water restriction, UTI treatment is increased water intake. Okay, so both are entirely different. Okay, treatment is entirely different. SAADH, you have to restrict the water. Urinary tract infection, you have to give more water so that the urine will be cleared very fast. Now, how do you treat sodium deficiency by oral salt? 1 teaspoon sodium chloride, that is 6 grams sodium. We take nearly 1 teaspoon sodium every day. Okay. So you may, South Indian diet, you may take little more than that, 6 to 8 grams salt every day we take. 1 tablespoon is 18 grams salt. 1 teaspoon is 6 grams salt. Okay. So when you have a patient with hyponatremia, like a patient come with hyponatremia due to patient is having hypertension, most of the doctors tell that you restrict the salt, but patient will think that if I don't take salt, BP will improve fast. So they don't take salt at all. So eventually they will develop severe hyponatremia. In that case, you can advise to take the patient to take more salt, that will not increase the BP. That is very important. You should remember that more salt may not increase the BP when there is hyponatremia. You are supposed to correct the hyponatremia fast. So you can give excess salt, but excess salt every day taking more salt will not be palatable. So you fill the B complex tablet or some other capsule with salt and give it. Okay. So sometimes you'll have to give 12 gram, 16 gram salt. So normal diet with additional salt should be filled in capsules and to be given. Now, if the patient is having dehydration, water deficiency with hyponatremia, you can go for normal saline or DNS. Normal saline is the ideal choice. Normal saline contains around 154 milligrammes in 1 liter of water. So, you can give normal saline in volume depleted state. Now, if the patient is having hyponatremia with symptoms of hyponatremia, you are not able to correct with normal saline, you are not able to correct with oral salt, or you anticipate a problem like low GCS and seizure can happen, you can correct it faster way, but you can use another drug, that is 3% saline. 3% saline contains more salt. I have previous slide I have shown you. 3% saline contains 513 milligrammes. So each 100 ml will have 51.3 milligrammes. So 51.3 milligrammes, each 100 ml contains 51.3 milligrammes. Okay. Before starting 3% saline, you have to actually calculate the sodium requirement in this patient, then only you should give 3% saline. So I will show one example for calculating that. For example, 50-year-old male patient, 70 kg with sodium levels of 110 milligrammes. How do you transfuse 3% saline? That's the thing we are going to discuss. So desired sodium in this patient, 8 to 12 only you should correct, 8 to 12 milligrammes in a day. So desired, I am taking desired as 122, or you can even take 120, that is a safer range. So 122 I am taking. So desired sodium minus the actual sodium into 0.6 into body weight. 60% is water, that is 0.6. So that will give you the answer. The answer in this patient is around 504 milligrammes. So each 100 ml is having 51 milligrammes. I require around 9.8 bottles in 24 hours. Okay. So that much I have to give. So per hour infusion has to be 40.8 ml per hour. That's how we calculate the deficiency status. You can use this chart, or you can take any other samples and calculate the sodium, then only give 3% saline. Every 4 to 6 hours, you are supposed to check the sodium levels in this patient. That is very, very important. You have to check the sodium levels and calculate. But in severe neurological symptoms, you can even push the sodium 100 ml over 60 minutes you can give. If the 10 to 60 minutes it is written in books, you can give little faster, 2 ml per kg per hour can be given. Okay. That should be given if the patient is in coma or seizures. This is very important. Coma or seizures you have to give in a faster rate. Osmotic demyelination syndrome is a syndrome which occurs when you correct the chronic hyponatremia in a faster pace. So that can happen. Patient can have a locked-in syndrome-like feature. So that is possible. Now we know that it is not central pontine myelinolysis. It is osmotic demyelination syndrome. In that, one component is central pontine myelinolysis. That is a locked-in state-like feature. Other one, the whole brain can be involved. Extrapontine myelinolysis. So central pontine and extrapontine myelinolysis together called as now osmotic demyelination syndrome. So that can happen in a faster correction. Very rarely it can even happen in a slow correction. Now SIADH treatment is slightly different from other treatment, because you know that there is a water retention. Water retention is there. then loss of sodium through the kidneys. So water restriction is the first strategy. Second strategy is water removal through kidneys by diuretic. Third strategy is preventing the loss of sodium by tolvaptan, that is vasopressin receptor antagonist. So water restriction is first strategy, giving diuretic is the second strategy, third one is vasopressin receptor antagonist. In between, if we are not satisfied with your routine treatment, you can even give 3% saline. Most of these patients may require 3% saline because they may have weakness, altered behavior, seizure like that. So you can give 3% saline or oral salt, whatever it is discussed in the previous slides. Tolvaptan dose is 15 milligram once daily or twice daily can be started. That will prevent the loss of sodium. So that can be prevented and slowly you can correct it. Monitor the LFT during your treatment. Conivaptan is a IV preparation that also can be tried, but commonly doctors give tolvaptan. So nowadays tolvaptan has got additional indication, that is in cardiac failure with hyponatremia. Instead of giving Lasix, you can give tolvaptan. When you are giving Lasix, both water and salt will be removed. When you are giving tolvaptan, water will be removed. But this has not come in standard guidelines. Many papers are there regarding use of tolvaptan in cardiac failure. You can read about that and use it. So I have completed one of the most common topic in emergency room, that is hyponatremia. There are three different types: normovolemic, hypovolemic and hypervolemic. Depending on the clinical scenario, the treatment also will slightly vary according to this type of water deficiency state or water excess state or normovolemic state. Thank you.